Welcome, everybody. Thank you for waiting. I apologize for the technical issues. That was all my fault. But thank you for joining us. My name is Kim, and I work with Dr. LoSasso and the team. I'm often the first person that you speak to if you reach out through our website, through email, phone, and then I help connect you to Allison and the team for next steps. We know that the Pectus journey can be a challenging one, both physically, emotionally, mentally. And we have a staff here that is here to help. We're here to answer all your questions and just make you as comfortable as possible as you go through this process. And that's how these webinars came about. So every month we do a new webinar focusing on different topics of Pectus. Today's topic is the testing protocol. Testing is, of course, very important to the process because it helps us make sure that we are as prepared as possible for the surgery. That being said, it can be a little bit of a daunting process to go through this series of tests and where do you do it and how do you do it. So we're going to help break it down today. And we also want to let you guys know that if you do want to go to New Jersey to complete all your testing, that's something that we can help arrange, and it can be completed in 3 days. There isn't a testing facility near you, or it just becomes too convoluted, or the insurance process is daunting, then reach out to Allison or our front office team, and we can help coordinate a visit for you guys to set up all that testing. So with that being said, Dr. LoSasso is going to do a breakdown of these tests. And as always, we will be staying around for Q&A afterwards. So feel free to type your questions into the chat box as you think of them, or hold on to them to the end, and we will call on you to ask your question or type in the chat box at the end. Thank you. I'll pass it on to Dr. LoSasso now.
Thanks, Kim. And welcome to everyone. I'm so glad to have you again. I'm coming to you from my home in Edgewater, New Jersey, which is just right across the Hudson River from Manhattan. And I am very excited about this webinar because this is really the first major step in the journey. And often we as providers are not very thorough in explaining all the little nuances, all the little bits of information that a patient really needs in order to understand why the testing is so very important, not just to those of us who are providing care, but it's important to you, the Pectus patient or the parent of a Pectus patient, in your own internal processing of the specifics related to you or your loved one's Pectus deformity. Pectus deformities come in many different varieties and with different degrees of severity. And so I try to tell patients and families that no two Pectus deformities are exactly the same. And to that point, it's absolutely necessary to understand a given patient's individual anatomy and physiology, and it's the testing that really goes to the heart of that. So without further ado, we're going to do hopefully a very thorough deep dive into the tests, why they're ordered, and what some of the results actually mean. Great. So a little bit about my background. I did my undergraduate work at Yale University and went on to medical school at the University of Florida in Gainesville, Florida. Thereafter, I did my general surgery training in Los Angeles at UCLA and at Cedars-Sinai. And then went on to do my pediatric surgical fellowship at Columbia Presbyterian Medical Center in New York City. Following my training, I was the director of chest wall deformities and the program at Rady Children's Hospital in San Diego. I also directed an adult program at the nearby Sharp Memorial Hospital. I think the important thing for the community to know that I was mentored directly by Dr. Nuss. I spent quite a bit of time with him in Norfolk, Virginia, learning the operation directly from him, and more importantly, learning also how to preoperatively and postoperatively take care of patients with pectus deformities. Next slide. So I did my first pectus operation, my first Nuss procedure in 1999. So I've been doing this procedure for over 20 years, and I've done over 1,000 Nuss procedures on patients from ages 12 to 53. I just recently did a 53-year-old gentleman. About 20%, maybe a little bit more, having come to the East Coast, of my patients are over 21. I moved my practice back to the East Coast in 2017 to join an old mentor of mine from Columbia, Ranjandir Gandhi, and his partner and my partner, Dr. David Friedman. And we do all of our pectus surgery at the Valley Hospital in Ridgewood, New Jersey. And there I operate on both young adults and adult patients. Next slide. The Valley Hospital is a tertiary hospital. It does a lot of specialty surgical work, and it's been a wonderful home to me for the last 5 years, doing this very, very important surgery that I'm so passionate about. Next slide. This is my team. Some of you may have already met Kim, who gave the introduction. And maybe some of you also have talked to or been introduced to Allison Tan, who is my physician assistant. Also, she runs the Nuss program administratively. She is in the operating room with me, assisting along with Dr. Friedman. And so she is an integral part of both the administrative and clinical phases of care. Helping her within the office is both Georgia and Linda, who do scheduling and logistics, and Linda Banca, who is our insurance specialist and a person who really has a very deep understanding of the different insurance programs and how they interface with pectus surgery and pectus providers. So a wealth of information who will assist you in understanding a bit better what your responsibilities may be financially in getting a Nuss procedure performed. Kate Parberry is our webmaster and a person who does a tremendous amount of the technical work behind staging these webinars on a monthly basis. Next slide. The outline for tonight is basically giving you an overview of what pectus is. For most of you, this will be information that you already know, but I want to make sure that anyone who might be tuning in later or find us on the web or doesn't really know the basic primer of what pectus excavatum is, will have some fund of information necessary. So we'll go through a pectus overview. I'll talk about testing protocols and what the results actually mean, and then we'll go into Q&A. Next slide. So pectus deformities in general are a genetic condition, i.e. a person with one of the three forms of pectus has inherited through their family a predisposition for the ribs in the front of the chest adjacent to the breastbone, which are made of cartilage, growing in an excessive way and in a way that is abnormal and asymmetric. So as these ribs in the front that are cartilage grow abnormally, they then cause the chest to sink, which is the diagram to the left. Pectus excavatum, to excavate is to dig a hole, or cause the chest to protrude, as in the middle diagram, which is called pectus carinatum, or rarely, both conditions will exist within the same patient, the so-called mixed deformity, which is also known as pectus arcuatum. It is, regardless of form, the most common chest wall deformity that affects human beings, and its overall incidence is quite high. I tell people on a sunny day on a beach anywhere in the world, if you know what you're looking for, you'll likely see a young man or an elderly man with their shirt off with some form of pectus. It's that common. So 1 in every 350 to 450 people on the planet have some form of pectus. It may not be severe enough to warrant a correction, but it is a very, very common chest wall malformation. It affects both men and women, but men much more than women. 4 men to every 1 female that we see. And next slide. It's important to know that each and every one of these deformities are exceedingly unique, and therefore testing is an absolute necessity. So the overview of pectus testing is starting with cardiology and doing a cardiology evaluation. So a cardiologist would see you, examine you, and perform an EKG, which is a test to see if the electrical conducting system of the heart is working properly, and an echocardiogram where sound waves are bounced off of the heart, creating an image that can be evaluated. The next is pulmonary consultation done by what's called a pulmonologist. And in the course of that evaluation, pulmonary function testing will be done. And that's essentially just breathing in and out slowly and rapidly, and testing for the volume of air that is able to be taken in and exhaled in a given amount of time. There are norms for that, and those norms allow us to assess the sort of volumetric function of the lungs. The next most important of the testing is a cardiopulmonary metabolic stress test. Now, most people are aware of cardiac stress tests. They're commonly done for the evaluation of patients with chest pain to rule out coronary artery insufficiency or a lack of blood supply to the heart muscle. This test is different. This test is not measuring whether or not you're getting adequate blood supply to the heart muscle, but rather how well, when aerobically stressed, does a patient consume oxygen. And there are norms for that then can be applied to the results of a given patient when they're being aerobically stressed, either on a bike or on a treadmill. And an assessment can be made of that very important relationship between the heart and the lungs. The next is imaging. This is critical in allowing the surgeon to know, one, what is the severity of the deformity. Again, we're talking about exclusively pectus excavatum now, or sunkenness. And most of us do MRI imaging of the chest, and I'll explain why a little bit later. Ophthalmology is very important because we need to determine whether or not there are any of the anatomic signs of connective tissue disease. And an ophthalmologic exam of the eye is one way that we can do that. Allergy testing, for those who are going to proceed with a surgical intervention, a Nuss procedure, it's important to know whether or not there's any metal allergies. And lastly, a genetic evaluation. And I'll explain to you a little bit about why and when that's necessary. Next slide. Starting with cardiology, the electrical conduction system can actually be adversely affected by the compression and displacement of the heart. And therefore, the normal electrical activity of the heart, which is seen in the cartoon to the far right, can be abnormal, showing things like a block of certain of the pathways of that electrical system, and some atrial enlargement, which can be seen when there's a significant amount of right-sided compression and obstruction to flow between the right side of the heart and the lungs. So these kinds of findings, which are abnormal, can be seen on an EKG of a patient with a significant pectus deformity. Next slide. Echocardiography is the next most important thing that the cardiologist will do. And essentially, it's non-invasive. So the instrument does touch your skin, but it just lays on the anterior chest wall. They apply a gel to the chest that allows the sound waves from the transducer to penetrate the chest, and essentially the sound waves and the bouncing of the sound waves off the heart and the structures of the chest, internal chest, will then create an image that will allow us to see the deep anatomy of the heart. The chambers of the heart, remember there are 4 of them, 2 chambers on the right and 2 on the left, a right atrium and a right ventricle, which pump to the heart, to the lungs, and a left atrium and ventricle, which pumps to the tissue of the body. The imaging is quite sharp. We can see problems with the actual valves of the heart, and we can also assess the great vessels, they're called, of the mediastinum, or the central part of your chest. And the most important of that is the aorta, which can sometimes be abnormal in patients with connective tissue disease. So the echocardiogram allows us to see the heart structurally and see it in real time as it's beating and as it's delivering blood both to the lungs and to the body. Next slide. The most common issues that the echocardiogram can pick up are mitral regurgitation, which is the main valve between the left atrium and ventricle, which can sometimes be leaking. That's called regurgitation. And there can also be a sort of floppiness of that valve, which we call mitral valve prolapse. We can also see at times, especially when there's a severe amount of sunkenness, compression to the right ventricle in particular, that being the most anterior of the chambers of the heart, closest to the chest wall that is sinking down towards the spine. And you can sometimes literally on echo see that compression. In addition, as I mentioned before, aortic diameter is exceedingly important to know because it can be abnormal in patients who have an associated connective tissue disease, which is rare, but it is sometimes part of the overall clinical picture of a patient with a pectus deformity of any kind, I might add. But again, it's very, very rare that it is associated with pectus. Next slide. I just wanted to show you what aortic dilatation looks like on echocardiogram for a patient. Next slide. Pulmonary function tests, we talked about that. It's the volumetric measurement of a patient breathing in and out. It's generally done by a respiratory technician in the context of a pulmonary medicine evaluation. The most common abnormalities we see in patients with pectus are mild restrictive lung profiles, and also there can be measurements that would suggest that there's exercise-induced asthma, but in fact, much of that is just the compression and displacement of the heart. We test for pulmonary function because so often patients present with pulmonary-like symptoms of shortness of breath. It's important to discern true pulmonary disease from the symptom of shortness of breath, which is created due to circulatory, the circulatory effect of the compression of the heart by the sunken chest. So you have to try to separate intrinsic lung disease from the cardiopulmonary effect of the deformity creating compression and displacement of the heart. Next slide. The cardiopulmonary stress test is extremely important because this test really gets to the core of the question. I can't tell you how many times during my many years treating patients with pectus that parents in particular will ask, is the pectus affecting the health and well-being of my son or daughter? And of course, that's the crucial question that needs to be answered. And this test gets at that question. And essentially what we're trying to do is simulate the real world experience of patients doing something active and then experiencing symptoms of shortness of breath. And getting at why that might occur is what the metabolic stress test does. So what we're looking at is how well are patients during stress and exertion utilizing oxygen or consuming oxygen. There are norms for that. And when that relationship between your heart and your lungs is being adversely affected by compression and displacement of the heart, that pathophysiology, that pathologic physiology can be measured and quantified by stressing the patient either through a treadmill or a stationary bike, have them exercise to the point of being unable to proceed, and then measuring their oxygen consumption against the norms for their age and their sex. That is exceedingly helpful in answering the question as to whether or not the deformity is causing physiologic abnormalities for the patient. Next slide. Imaging is critical, one, because the surgeon needs to have a roadmap to how the deformity, the specific deformity, is altering the normal anatomy of the chest cavity, but it's also important in terms of obtaining permission, approval from the insurance company with regards to the severity meeting the standards that have been established in terms of severity to warrant a correction. So for those two reasons, a surgical roadmap and insurance approval, an imaging study is an absolute necessity. Now, this is important for you all to know that it takes a certain amount of experience and knowledge to know how to conduct an MRI of the chest and heart that is done in order to determine whether there's a circulatory effect by the deformity, and also to know how to measure correctly and accurately the degree of sunkenness. That's called the Severity Score. It's also called the Haller Index, named after Dr. Alex Haller, who was a professor of pediatric surgery at the Johns Hopkins Hospital, who came up with this great idea of measuring the width and depth of the chest, generating a ratio, and then setting norms for that measurement, which we'll talk about in just a minute. A CT is a quick study, but it does involve radiation exposure. An MRI takes more time, but it's also more detailed. There's no radiation involved, and it allows us to see both the actual degree or severity of sunkenness, but also to really know better how, for a given degree of sunkenness, that might be affecting that critical connection between the heart and the lung, which is a right-sided cardiac function, which can be affected when one has pectus excavatum. Next slide. So the norms for the severity score or Haller index is 2 to 2.5. It's important for you to understand that that just simply means that if you measure from side to side and front to back, the normal chest is about twice as wide as it is deep. So those two measurements should be somewhere around 2. When you exceed 3.2, then you've reached the threshold for permission to proceed with correction should a given patient and/or family wish to do so. Mild is up to about 3.9 or somewhere between 3.2 and less than 4. When you get to 4 and above, that's moderate. And when you're over 5, depending on how individual specialists will define it, because there is some poetic liberty here, but for me, a 5 has always meant a severe deformity that generally requires an escalation of therapies in order to achieve an excellent result. We're very blessed at the Valley Hospital to have Dr. Himanshu Gupta, who is not only a radiologist, but also a cardiologist who has, taken a very, very active interest in our Pectus program and reviews all of the MRIs that are done on patients who are studied at the Valley Hospital. He's a world-renowned radiologist and cardiologist and a very valued member of our team. Next slide. So here's just a diagram showing what I tried to describe a moment ago. The distance from side to side is the longest distance. The distance from front to back is measured from the back of the breastbone or sternum to the front edge of the corresponding thoracic vertebral body. So it's not hard to understand that the transverse distance is the greater distance, and that's a fixed distance that doesn't change as the chest sinks. The anterior posterior front to back distance is the one that changes, and as that reduces in distance, the overall ratio increases. So you're dividing a fixed big number by an ever smaller distance from front to back, driving the overall ratio up. Next slide. The ophthalmologic exam is a very important exam because it helps the provider know if there's any of the stigmata or signs, ocular signs of connective tissue disease. So if you have Marfan syndrome, often you will have a finding on the examination of the eye, that's called a slit lamp test, that shows your lens, which is in the front of your eye, to not be normally positioned. So there's what we call ectopia of the lens that can be mild, moderate, or severe. But when it's present in a patient with Pectus, then it prompts a further evaluation of the patient, usually through a visit to the geneticist for genetic testing for connective tissue diseases, the most common of which is Marfan syndrome. Next slide. Allergy testing is done sort of as the workup is in its later stages, because knowing whether or not one has a metal allergy is important only if you're going to proceed to correct a deformity using the Nuss technique. The Nuss technique, of course, involves implanting a piece of metal into the chest as an internal brace to move the chest forward, much like putting braces on crooked teeth, allows for force over time to reconfigure the chest and render a permanent correction to the chest wall if there's sufficient time allowed. That being said, about 12 to 14% of people in the world have a metal allergy that they're unaware of, the most common of which is to nickel. And nickel is part of stainless steel being the most common bar that we use. So it's very important if you're going to move forward with a Nuss procedure, and if you're surgeon is going to potentially use a stainless steel bar, that you're tested to make sure you don't have an allergy to one of the components of stainless steel. So it's very important to know that, because if it's not determined preoperatively and one has a stainless steel bar implanted that one is allergic to, it can cause pain and delayed wound healing, both of which are important to avoid. I personally like to use stainless steel bars because I bend my own bar and I can use a bending device to millimeter by millimeter bend the bar to perfectly fit into the chest and achieve the mutually agreed upon cosmetic result that the patient and I discuss preoperatively. That's a little bit harder to do when the factory bends a titanium bar, which is the alternative for those who are allergic to stainless steel. Now, having said that, there's a lot of collaboration between the manufacturer, Biomet Zimmer, and those of us who are ordering titanium bars with regards to the shaping of the bar and the length that the bar should be optimally. So even if you have an allergy, you can't have a personally shaped stainless steel bar by me or the surgeon who's treating you. Through collaboration and meticulousness, the surgeon and the manufacturing company can arrive at a bar which will fit well and accomplish a good end result. But it does require a collaboration between the surgeon and the manufacturer when a titanium bar is needed. Next slide. This is some of the testing. This is how it looks. It's a patch test, and we're testing for nickel, titanium, molybdenum, copper, potassium, dichromate, chromium, and magnesium. Those are the alloys that must be tested for. Next slide. Genetics, if needed, would be done if, one, there is a history of connective tissue disease in the family. Two, the patient has certain overt appearance of someone with a connective tissue disease, because there's a certain look that patients, especially with Marfan, have. Or there is either an abnormal ophthalmologic exam, or there's an abnormal echocardiogram showing aortic dilatation. Those would be absolute indications for obtaining genetic testing. It's important to know that there is a link between genetics and connective tissue disease, okay? And the best way I can describe the incidence is the following. Pectus deformities in patients with Marfan's is extremely common. However, Pectus patients with Marfan's is quite uncommon. So if you have Marfan's, chances are you're going to have a Pectus deformity. If you have Pectus, don't look particularly like someone with a connective tissue disease. The screening is necessary, but the chances are that you're not going to have a connective tissue disease. If you do have one, or you have findings which would suggest one, then you need a physical exam where measurements of your body are done. There are criteria that are used to score certain physical findings, and adding that score would then determine whether or not you have some of the physical findings that would suggest you have a connective tissue disease. That criteria is called the Ghent criteria. As we talked, you have to know the results of the echo and ophthalmology, and what is done differently if you have a connective tissue disease is something that needs to be discussed between your surgeon and you once you are identified as having a connective tissue disease. In general, it does not rule out having a Nuss procedure, but there are some very important issues when one does a Nuss procedure on a patient with a connective tissue disease, and individual surgeons deal with that set of circumstances slightly differently. So I'm just going to leave it that that's a unique situation, quite rare, and requires further explanation when that is determined to be the case. And that should prompt a thorough discussion between the patient and the operating surgeon. Next slide. So again, the overview is cardiology consultation, pulmonary consultation, cardiopulmonary metabolic stress testing, an ophthalmologic exam, an allergy assessment, and genetics if needed. That is the sum total of what should be done for every patient, whether or not you're going on to have a Nuss procedure. It's important to have that information just because you have Pectus, so that you have a deeper understanding of how the deformity might be affecting your overall health. And then what you do with that information in terms of whether or not to proceed with correction or not is a completely different conversation. So don't allow the decision about whether to move forward with surgery or not to prevent you from going ahead with the evaluation, because there's a lot of valuable information that you'll receive just by going through the testing part of the process. Next slide. For those of you who live in places where the medical community may not offer some of these tests, or that the level of sophistication in the medical community that you live close to might not be specialized in the way that they would need to in order to provide you with the most accurate assessment of your Pectus deformity. I want you to know that we have a complete team of specialists here in Bergen County, which is the county where the Valley Hospital is located and has a number of different communities within that county. But there are a number of very fine cardiologists, pulmonologists, and of course, Dr. Gupta as our radiologist and cardiologist to help you with this evaluation. If you choose to come to New Jersey, it would take about 3 days to have all of the testing done using the resources that we've assembled here. And then as part of that, once it was all completed, you would come see me and we would process those results. So we're here to provide that service to those of you who may not have it close by. For those of you who have excellent medical facilities close to where you live, I'm more than happy to interface with the people who might be providing you with this evaluation, to answer questions, to process results. And clearly, I'm here to receive those results and give you my opinion as to what the results mean and what's important for you to understand completely moving forward in the process. So either way, we're here to help, either to provide the studies, provide the workup and the resources here, or to interface with those closer to your home who may be fulfilling that role nearby for you.